All right, welcome everyone. We're going to give folks maybe another moment or two to join on. Before we get started with our mindfulness and then jumping in, we are going to do as we always do and just sort of take a pulse on how folks are feeling right now. So thanks in advance for responding to the poll. And then in a moment or two, I will turn it over to Santoy to get us started with an activity.
Hello, good afternoon, everyone. Welcome to your Wednesday. For some people, it might be the last day of school, week of school, and for some, there's one more week, but just wanting to acknowledge that we're heading into the solstice and kind of the deeper part of the winter. I want to invite you into your body, and I'm going to do that in a few different ways if that feels like a good place to be in right now. And if it doesn't, then do whatever feels best for you. We're going to just start by connecting with our feet in the ground, and you can do that by wiggling your toes on the ground. You can press your heels into the earth or into the floor. Just take a moment and feel the earth, the floor, the carpet beneath you. And then you can relax that when you're ready. You might have noticed your quads tighten during that time. And then I'll invite you to just do a little bit of walking in place. You can do that standing or sitting, but just again, just in bringing us back to, we're so much in our heads, but bringing us back down to kind of this earth in the lower parts of our bodies in whatever way that feels. You may want to just wiggle a little bit in your chair, in your seat, if you're sitting down. And then kind of noticing your spine, just bringing your attention to your spine and reaching your head, imagining it reaching all the way up to the sun, to the stars, to the clouds, as you feel a little bit of lift and creating a little bit more spaciousness in our bodies. And so I just came back with also a few of my colleagues from the Advancing Mental Health in Schools conference in New Orleans and had an amazing time. And one of the things I learned there was an exercise that just has 3 gestures. So I'm going to invite you into that with me. And first is just placing your hand on your heart, if that works for you for a moment. And as you're doing that, just bringing your attention back to yourself by feeling maybe the warmth or the coolness of your hand, the pressure on your heart. And take a moment of curiosity of just like, how am I doing right now? What thoughts, feelings, sensations are present for you in this moment? If it's available for you, I invite you to take a breath kind of full in your lungs and really focusing on the exhale when you're ready. The second gesture I'm going to invite you into is really just a hands out. It doesn't have to be shoulder up, but just kind of on your laps or low, but just having your hands and your palms open. And bring to mind, like, what are you holding? Or is there something that you want to hold to bring some energy, to bring some light to? Just notice kind of what are you holding? And is there any way in this moment to bring it some kindness, compassion, healing, light, love, whatever works for you in this moment? And again, I invite you to take a breath, filling in your lungs, creating some space in your body, and focusing on your exhale. And the last gesture I invite us to do together is bringing your hands together, again, just in your lap, or either you can be holding them. I'm holding them up to the camera so you can see. So either like this or like this, but taking a moment and in this gesture, reminding yourself of connection, right? Who are the people, the communities, the land, the water, the animals, the children? Taking a moment to remind yourself of the places where you feel connection and where you are in connection with your colleagues, with our work. And I invite us again just to take one last intentional, thoughtful breath, filling up our lungs. And when you're ready, allowing a nice long exhale. So thank you for joining me in that. That was taught to me by folks who are doing resiliency work for educators in Boulder, Colorado. And I will pass it back to you, Lauren.
Amazing. Thank you, Santoy. I needed that on this December afternoon. And I'm so happy that so many are able to join us today. And so without further ado, I would like to introduce our guest speakers today and turn it over to them so that they have time to speak before we go into our case-based learning. So first up today, we have Milena Kaufman, who is a child and adolescent psychiatrist at UCSF Benioff Children's Hospital, Oakland, and in the Department of Psychiatry and Behavioral Sciences. She provides clinical care at the UCSF Autism Spectrum Disorder and Neurodevelopmental Disorder Clinic. She's board certified in both general and child psychiatry. She specializes in assessment of co-occurring psychiatric problems in individuals with autism and other neurodevelopmental disorders, pharmacotherapy, and behavior therapy. Dr. Kaufman is trained in pivotal response therapy, which is a behavioral intervention for autism. She also collaborates with other clinicians and provides diagnostic assessments of autism and other NDDs. And next up, we have Maricela, who has been in the field of ABA since 2012. She worked in-home for 11 years, where she served as a trainer and clinical director. She has vast experience completing parent training in all things insurance related. Most recently, Maricela shifted as a contracted clinical supervisor, consulting in the Oakland Unified School District. She divides her time between Oakland's young adult program and non-public schools, consulting with teachers, schools, and case managers. So I'm so thrilled to have you both with us today, and I will turn it over to you, Dr. Kaufman.
Hi, everyone. Thank you for the introduction. So today we'll kind of, as you know, rapid fire to make sure we can cover as much as we can, and then answer any questions you have after. You can always please email because I know things will come up and there's sort of never enough time. So today we'll go through the autism spectrum disorders and neurodiversity, just to learn a little bit more about how we can help these kiddos and adults. Okay, next slide. So we don't have any disclosures to report for today's presentation, and just that our UCSF CAP is supported by the federal and state grants that keep us going. Next slide. Okay, so today's learning objectives. So first we'll go through how what the options are and the processes for autism diagnoses in the school setting and the regional center or outside of the school setting. Identify some aspects of ABA or behavioral therapy and talk about some of the different types of behavioral therapies. Connect on 3 features of the social model kind of in your day-to-day work, and then go through where kind of a really valuable resource and way that we can check sort of our own behaviors and kind of how we are observing and identifying and talking about and helping these kids and adults with autism. Okay, so to sort of have the most simple breakdown in how we identify and diagnose autism is this sort of breakdown of age. So below 3 years old, we have sort of a different way of going about the process of diagnosis versus when kids are 3 and up. So under 3 years old, the first place we hope that autism symptoms are caught or within primary care, within their pediatrician visits, as families are going and filling out those developmental milestone screeners. We're hoping that the pediatrician sort of catches that something is different about their development to get the ball rolling on an autism diagnosis. Some pediatricians will diagnose autism. Many will not. Sort of true also for us in child psychiatry. Some psychiatrists will diagnose autism and some will not. Most of the time what happens is the pediatrician will identify concerns that lead them to have, suspicions about autism, and they will recommend that the family connect with the regional center, which is based by counties within California. And then the regional center does their own full diagnostic evaluation and are able to give an autism diagnosis to these kids, as well as other diagnoses if they're appropriate, like intellectual delays, speech delays, and so on. And then the regional center, if these kids are under 3, sets up something called early intervention, or the Early Start program. And that's unfortunately only applicable for kids that are 3 and under. And that provides the services that we sort of think about for autism, including speech, occupational, sometimes physical therapy, and then of course our behavioral therapeutic interventions, to be able to really kind of, load them up with as much support as we can in those early years. Then when kids are 3 and up, of course, we're still hoping that the primary care is sort of that first line as they're, seeing the child as they're developing. And the regional center is still available and an option. We still kind of use it as a, a great support, but it no longer sort of can prioritize in the same way, because their priority really is for the 3 and under. And so there are unfortunately longer wait times for our kiddos that are 3 and up to be assessed by the regional center. Still, certainly they can, and many of our patients do, but it's a longer wait time. And then they don't qualify for those early intervention services. And then insurance begins to play a role as well for these kids that are 3 and up. And so we will sort of often simultaneously ask families to contact the regional center and start going through their insurance providers for agencies that can help support them with those services that they need. I see a question. Once they turn 18, they no longer have access to the regional center, ? So they have lifelong access to the regional center. It's a great question, and actually a super important one, because sort of the 2 areas of life where we really, lean on the regional center is that 0 to 3, essentially, because that's their primary role. And then when kids go and either graduate at 18, or if they're on a certificate track from school at 22, after they no longer, qualify for services under school, regional center takes over lifelong. So great question. And yes, regional center is very important for our adults after 18. Okay, next slide. And feel free to just pause me and ask questions in a moment. Okay, so the regional center, sort of kind of what is this and what can it do? So there's something called the Lanterman Act that was established, and this really sort of set up, rights and services for these individuals. And that is now mostly provided through the regional center, but the Lanterman Act also included things like our IEPs and 504 plans, and gave, the rights essentially for these individuals to be supported. Then again, sort of coming back to that, Lanterman Act also included that 0 to 3 age, with the early services being provided. The other things that are sort of important that the regional center and Lanterman Act kind of helped with creating is, so within the regional center, each one of our patient students, each one of these individuals are assigned a case manager within the regional center, and that person should be sort of the biggest support for our families in helping to guide and obtain the services that these individuals need and legally should be provided. The self-determination program, for the IPP. So that is stands for Individualized Program Plan. And that is what the case manager creates for each one of our patients and students, because we know that, right, autism is a huge spectrum, and we really base, supports on individual needs. It's not a one size fits all. So that case manager should be working with the family and the patient student to figure out what should their individualized program plan look like. And the self-determination program encourages those participants to be able to, kind of have their voice heard and really be a part of creating that individualized program for themselves, so that it's really a team effort, and that we're including, the student and patient themselves in this process. Okay, next slide. Okay, so what are all the things that Regional Center can do for these individuals? So again, that individualized program plan, the IPP, they can provide counseling, genetic counseling. They provide the case management, family support, advocacy, again, those early intervention services until age 3, respite care, which is very important for a lot of our families when they just need support at home, crisis support, ABA providers. So Regional Center will help with those behavioral therapies and help provide ABA services. Assessments as well. Again, that self-determination program, so that those participants can be a part of creating their individual plan and having their voices heard. They can help with long-term placement. So that kind of comes back to that question about 18 and up, but certainly for 18 and below as well, right? Sometimes there are concerns about being able, right, to be able to support some of our patients and students in their home for either safety reasons or for other reasons. And so Regional Center helps with group homes and with more long-term placements as well as they grow older and need lifelong, right, support within their living space. Okay. How does primary care connect with the case manager? So I will let Shelley answer more from a primary care point of view, but certainly I think probably similar for us in psychiatry. We do get ROIs to speak and connect with the Regional Center, and then we very much try to work as a team, because we know the more communication and the more everyone is, a unit working together, the better off our patients and students will be. And yes, parents will help to provide and sign those releases. Okay, next slide. Okay, so now briefly talking about what kind of interventions do we have in terms of therapy that can help support our patients and students. Next slide. Okay, so ABA, or Applied Behavior Analysis, is really sort of the kind of oldest, and where kind of all of the behavioral therapies that I'll kind of talk about that are not ABA, but have certainly stemmed from it, because ABA is sort of the if we had like, a tree, it's sort of like the roots, and then we've had these different branches kind of come off of ABA. And it's really just the science and the model for understanding of how behaviors can change and be adapted to certain environments. ABA behavioral therapy techniques can be used at home, at school, out and about. It's really meant to be, just in every setting, and a different way of kind of teaching and communicating with these individuals. It is for across all ages. So sometimes there's thoughts that, ABA is just for younger kids, but ABA and some of the other behavioral therapies I'll talk about are adapted for many adults to work on living skills, to work on, improving social communication within dating, and really all ages, and really spans kind of all types of supports that these individuals need, not just for problem behaviors or challenging behaviors. And it is something that not just individuals with autism can benefit from. Certainly our patients and students with intellectual delays, global developmental delays, neurodevelopmental disorders, genetic disorders, it can be applicable and very helpful to them as well. So the sort of classic ABA that we think of, and that a lot of times parents will kind of come with, kind of the thoughts or questions about, is based on what we call discrete trial training, or DTT. DTT, excuse me. And historically, when sort of ABA was originated, DTT looked like, okay, there's a therapist sitting on, one side of the table and the child on the other side of the table. And the therapist is sort of over and over again, giving them blocks and having them repeat something, with the therapist creating the goal of, I'm going to teach this child the alphabet or the numbers. And that is sort of what discrete trial training looked like, kind of that over and over again. A lot has sort of changed from that original kind of classic ABA to what we call non-discrete behavioral interventions. And these are much more naturalistic. And many of those branches now that have come from ABA are more naturalistic because we know that oftentimes the more natural and the more it is based in the environment that they are in, then the more they're able to generalize those skills. So there are a lot of benefits from some of the more naturalistic developmental behavioral interventions, but I think a lot of ABA, even if it's just kind of called ABA, incorporates these very, very much so. So some of the names for these other more naturalistic behavioral therapies are Project Impact, Pivotal Response Treatment or Therapy, Early Start Denver Model. The list kind of goes on and on. On the next slide, there should be on one of these slides, there's an image to kind of show you the many naturalistic behavioral therapies that exist. Okay, next slide, please. Okay, so the main principles that ABA or behavioral therapies are based on is the ABCs, as we call them. A stands for antecedent, B stands for the behavior, and C, the consequence. And most of the time when we're observing our patients or students, or we hear from a parent, usually what the information we get or we've observed is the behavior, right? Which may be, my child is engaging in self-injury, or they're having, meltdowns, or they're eloping from school. Usually the conversation starts with the behavior. And then I ask parents to create or teachers or anyone that's working or knows this individual to help figure out the ABCs. So to look for the antecedent, what's happening in their environment, what could be a potential trigger, what's happening right before the behavior that you are seeing. And then the consequence doesn't necessarily mean like a negative consequence or a punishment, not at all. What it means is what is happening right after that behavior. So for example, right, if parents are telling me or school is telling me that their child is eloping, and right before they eloped, they entered a really loud, busy mall. And then the consequence, or what happens after, is they get back in the car and they go home. That consequence helps me to understand that it may be reinforcing that behavior, because we know, right, that the elopement, right, something made them feel very anxious. They eloped. And then what happened after the elopement made them feel potentially like, okay, this worked, right? So maybe I'm going to elope the next time because I didn't have to go into that place that made me feel more uncomfortable. So it's helpful to create this ABC model and to track it so we can better understand the function and the purpose of their behaviors. And when we think about behavior therapies and these ABCs, we're also thinking about 4 different functions of behavior. Those are sensory-seeking behaviors, attention-seeking behaviors, access to a tangible or preferred item, and then escape and avoidance behaviors. And most of the time, we can sort of identify one of those 4 that helps us to understand this ABC model and why the individual is engaging in that behavior. Okay, next slide, please. Okay, so here is just that umbrella with the naturalistic developmental behavioral interventions that don't use that sort of classic discrete trial training and are more kind of broad and in the natural environment. And those are kind of some of the names. So if you ever kind of run into them, like Jasper, what is that? So they're all sort of stemming from ABA. And pivotal response treatment, just for example, that was started by Lynn and Bob Cagle. They were students of Dr. Lobas, who created ABA. So they kind of used the things that they learned from ABA, but tried to make it more natural and more in the environment that the child is already in. Okay, next slide. Okay, again, just like a helpful graphic to kind of compare the classic DTT ABA with the PRT. Okay, next slide. Some other options we have when we think about behavior therapies, because again, not one size fits all. And there are times where ABA is the best option and times where something else may be more helpful. So we definitely use CBT or cognitive behavioral therapy for many individuals with autism. It's a good fit for those that do not also have an intellectual delay and don't have significant speech delay so that they can engage in CBT. But it is a modified version that also helps to focus on the more concrete behaviors. Peers is a social skills group that can be very, very helpful for a lot of the individuals that have trouble with social communication, trouble knowing how to hold a conversation, how to kind of engage, make friends. And I'll share this resource with Lauren because there's great videos for peers out of UCLA that are accessible for free. Okay, next slide. Okay, and so then just kind of broad information again about treatments. We really try to focus on skills-based treatments. And we know that the more active they are with practice, those are going to be the most effective. So things that are kind of broader, like just broad play therapy or psychoanalysis, are not really a good fit for the kids that we see. We really want to just work on specific skills for them. They need concrete directions, explicit teaching, and we want to give them ample amount of practice to feel confident in their skills and then be able to apply them out in the world with friends and other people. We absolutely know that parent involvement is the biggest key for success. We want our parents to be doing everything that we are doing with these individuals, and for parents to feel like they have the knowledge and the skill to be able to know how to interact and support their kids. We know we have to tailor, and these, recommendations and therapies have to be specific for the individual. Again, not a one size fits all. And again, they're going to vary based on age and where the individual falls on the spectrum. And it can range from play skills of, learning how to play with others, all the way right to those individual activities of daily living and adaptive behaviors. And we know that the earlier we start, those early interventions can really help to make significant gains for our students and patients in their language skills and their cognitive functioning and sort of overall severity, sometimes of autism symptoms. Okay, next slide. Okay, so then in terms of insurance and kind of what we want our families to do and kind of legally what they should be getting in return and supported, we want them to be able to reach out to their insurance as soon as we sort of identify these concerns. And by law, they should be given an appointment within 10 to 15 days. I would say easier said than done, but we do want families to then advocate and make a complaint with their insurance if that's not happening, so that we have this paper trail. We can have kind of more things to help support them if the insurance is not doing what it's supposed to do. They need to request case management through their insurance, and then we really encourage them to try to find out, what is the start date for therapy? When can my child start receiving services? And then again, right, if that's not happening, making the complaint with the insurance and with the Department of Managed Health care if it's not happening. Okay, thank you. I think I'm handing it over.
Hello, everyone. So we are very short in time. It's going to feel like I am flying through these slides. Do not fret, because I will be here after the meeting, post-meeting, to answer any questions. Feel free to reach out via email if you want further clarification on any other content that I am going to rush through. So next slide. Okay, so what we want to sort of discuss here is the IEP evaluation and support that's provided within the school district. The very first thing that we want to keep in mind is that we need parental consent. whenever we're trying to do anything with the student. Evaluations, assessments, data collection, observations. Parents need to be aware that we are providing a service. And so not to say that every service needs an AP, so an assessment plan filled out, but it's really important to get verbal consent for further type of supports, like a functional behavior analysis, observations, data tracking, amendments to the BIP. We definitely want to make sure we have an assessment plan signed and file. After this is signed, we have about 60 days from the time parents sign to the time that we complete assessments. Next slide. And so what do school districts provide for youth who are neurodiverse? So there are a couple of different either developing services that are already occurring at school, or some things that can be developing with the input of the team as a whole. And so school psychological evaluation is usually one of them. Functional behavior assessments is another one. And then we want to make sure that we are very individualized in the type of services that's being provided by the school district. Say, for example, there is a college-bound student who has autism, and the parent fears that an IEP might actually hinder their ability to get into college. And what these slides really portray is that IEPs are there for safeguards to ensure the implementation of accommodations that are the student needs. And so I want to make sure that we're continuously advocating for the student and that those services are provided. Next slide. Okay. And so there are a couple of different options depending on the need for the student. And so take this slide, look through this slide after the meeting. There are what we called least restricted to most restrictive environments within the school district. So we have within the school district what we call the general educational classroom. They provide SSTs, 504 plans, IEP support. Accommodations really depend on the need for the student. So that could be modifications to the coursework. It is individualized intensive support, or what we call one-to-one. This may also include small accommodations like seating, testing, spaces in which the student can complete all of their assignments. And then we have a resource report that also may mean that the student is pulled out from the current classroom environment to provide a more individualized support. After that, there is a special education, or what we call self-contained classrooms. And those classrooms provide part or whole time service under that specific need for the student. And they continue to have all the systems from the least restricted environment into their self-contained classroom. Depending on the student need, mental health diagnosis or mental health need, the school district also provides counseling enriched classrooms. So these counseling enriched classroom has a therapist and has an entire group of health support personnel who walk through strategies. You probably have heard of Dixon's ACT and AIM being implemented in some of these classrooms to really help support the students through planning and strategies and coping skills. And it's a huge emphasis that are done within the counseling enriched classrooms. If the behavior or the level of behavior isn't supported within any of these least restrictive environments, then the school can provide a referral to a non-public school. So a non-public school usually provides its own entity of education outside of the school district. And so they are called non-public schools, but in reality, they're like small private schools that focus on a specific eligibility for the student. That could be autism, it could be emotional disturbance. It could be other health impairment. And they provide its own counselors, behaviors, nurses, speech, OT, really, and it encapsulates all the services that the student need within this smaller classroom. The idea is that the shift to the non-public schools is temporary. And so they provide all the strategies that the student needs to then be successful in a least restrictive environment. And so the goal is to always move back through these levels. Ultimately, if the non-public school or the student is not successful in the non-public school environment, either due to the services that are being provided or lack of provision within those services, then the highest level of academic instruction is at a residential treatment center or an RTC. And again, very similar to the non-public schools, the idea is that the student will work themselves back through that level. And with my experience, we have success moving up and moving students down that level, a lot with Shelley's participation and orientation as well. We can move to the next slide. And so what I also want to make sure that we always keep in mind when we are providing services is that we are presuming competence and knowing what the student has to offer. And so there are 6 rules that I want to make sure that we all keep in mind when making suggestions and being really part of the team that's going to propel the students into a level that will gain them more independence and provide them more success for later in life. So the very first one is that we have to see every student as capable of learning. We must use age-appropriate language, tone, and vocabulary. We must speak directly to students, never about them or in front of them. Include students in their own planning and progress monitoring. This is huge for students who really have never been able to have that input into their own educational outcome. And it's a really important note to have when you are part of the team for the student. Number 5 is set meaningful and functional socioacademic goals aligned to the general educational curriculum. And 6, never use language classifying student based on functioning or developmental levels. Next slide. And so language really matters. And students internalize language. And we want to make sure that we are moving away from problematic terms into better terms. Things like using cooperation instead of compliance. Instead of talking about high and low functioning, talk about specific strengths and levels of supports. Don't use the word normal, use the word neurotypical, able-bodied. Instead of the word treatment, we can use the word support and strategies. Instead of using special ed or handicapped, use the terms neurodiverse, neurodivergent, disabled, neuroinclusive. Next slide. And so this continues the emphasis on the language and the language that we use. Take these slides. Like I said, we have more to cover during this meeting. So we're going to go through the next 2 slides. Yep. And so perfect. Thank you. And ultimately, what I really want for you to get out of this meeting is to really get comfortable with the assessment planning, records view, moving through the records review on what's important for the student, what have people said about the student in the past. Read the context in which the student has heard information. Has it been positive? Has it been negative? What are the current what's the current environment for that student and that he's in, who has been part of that collaborating team for that student. And so get really comfortable with that, get very comfortable with reading behavior intervention plans. Do these strategies reflect the hypothesized function? Do reactive strategies include strategies for managing dangerous behaviors? And ultimately reach out, collaborate with teams when you notice strategies may be unethical, especially if they're punitive. discuss management of behaviors that have historically required restraint or seclusion. This always must be the top priority for the student. Self-agency and advocacy is usually the first thing that goes when there's a restraint. And so it could have a lot of long-term effects for the students. And so it's something that we want to make sure that we're continuously discussing, especially if the student has had a history of that in the past. Keep going. And then get uncomfortable. Search anti-ableist groups and accounts, read articles. There's a great article about neuroinclusivity in supervision in your own workspace, working with employees who are neurodiverse themselves. Be comfortable with reading rep articles and listening to podcasts, and really ultimately is what are we going to do no harm? Next slide. And so here are some accounts for learning ableism and how we apply ableism in our own lives towards ourselves and towards others. Next slide. I think that might be the end of it. There is one last slide. So I added here called a self-reflection tool, which is a tool that helps evaluate your own practices and identifies potential areas of need, training, and education. Next slide. I think that should be it. Okay. So there are advocacy organizations, or what we called PTI centers. This are in the avenues of regional support, Gold Office of Disability Rights. There are multilinguistic organizations, such as the Chinese Parent Association for the Disabled, Fiesta Educativa, Family Resource and Navigating Programs.